Welcome everyone to the Choosing Wisely Health System Leaders webinar, which is co-sponsored by the ABIM Foundation, Academy Health, and Cost of Care. My name is Tim Lynch, and I'm the Director of Programs with the Foundation, and I will be moderating today. Wanted to let everyone know that this webinar is being recorded, and we can share a link afterwards for anyone that you might want to share the webinar with. Today we have two presenters, Drs. Howard Beckman and Brian Justice. And after their presentation, we'll then hear thoughts and questions from two respondents, Risha Gidwani-Marzowski and Jordan Harmon. And then we'll open it up to the full group for questions. Let me just start by introducing our two presenters. Dr. Howard Beckman is a senior consultant to Common Ground Health, a regional health collaborative for the Finger Lakes region of upstate New York. And he is a clinical professor of medicine, family medicine, and public health sciences at the University of Rochester. Dr. Beckman has been active in identifying and reducing low-value care since 1999. His first experience was as medical director of the Rochester Individual Practice Association, and based on their work on variation between practitioners, Dr. Beckman and colleagues spun off focused medical analytics and offered their experience working with changing physician behaviors to medical groups and insurers. Clients include Capital Blue Cross, the California Healthcare Foundation, and Massachusetts Health Quality Partners. Dr. Beckman has published his work on variation reduction in health affairs, the Annals of Internal Medicine, and the American Journal of Medical Quality, among others. And Dr. Brian Justice is a medical director for Excellis Blue Cross Blue Shield, focusing on pathway development and spine programs. He spent 28 years in a spine-focused chiropractic practice in a variety of private, industry, and hospital settings. Dr. Justice has published articles in peer-reviewed journals, served on national healthcare guideline development committees, and presented nationally on value-driven healthcare, quality improvement, pathway development, optimal interdisciplinary spine care, wellness, and holistic health. Dr. Beckman is going to begin the presentation, and I'm going to turn it over to him.
Thank you very much. Dr. Justice and I are pleased to have the opportunity to share our experience with you, and look forward to your questions and comments. So what we were interested in doing is reviewing the obstacles to choosing wisely, moving forward more successfully, and getting your thoughts on that. And then sharing the two approaches we think are necessary to move forward in choosing wisely. One is to review programs that serve as a plug-in for evidence-based efficiency and effectiveness to reduce low-value care, so that an organization at risk can have a program in place that is evidence-based and has been shown to be effective in reducing low-value services. And the second is in situations where that does not exist, to provide the communication skills needed to improve planned medical group and practitioner collaboration to identify and reduce low-value care. And that's what I've been personally doing for the last 20 years. So just some of the obstacles we see as being related to choosing wisely. I'm going to use my own words and say struggling some. Is provider reluctance to accept downside risk. I've been around in this work for 20 years. It seemed to me that practitioner organizations would move forward with accepting downside risk much faster than they have. Second, current data is largely in the hands of insurers. Insurers' information about a practice is partial. And so physician groups are most interested in conducting their work sort of payer blind. So having an insurer work to have competitive advantage may be a disadvantage to the medical groups. Third, in my experience, medical groups mistrust insurers and payers' use of savings. So if there's money to be saved, if the contracts are not explicitly developed, the physicians are concerned about where the savings will go. Fourth, medical leaders have bought the model of financial incentives being the primary motivator of change that's an external motivator, and I'm going to argue that internal motivation is more powerful than external motivation. And finally, I don't believe that we've argued sufficiently that low-value service improves patient safety, and I think we have to do that more aggressively. So to influence practitioner behavior, my suggestions are to align incentives clearly to encourage desired behavioral change. Having a fee-for-service system is an example of a misaligned incentive as far as I'm concerned, because people are encouraged to do more rather than to do what necessarily what's right. And I'm sure we'll talk about that more as we go on. The second thing is to offer easy to implement and administer effective, efficient evaluation and treatment programs. That's what Brian is going to talk about in his spine care program. And the third is to employ effective communication strategies to increase internal motivation. An example of what I experience most is Upton Sinclair said it's difficult to get a man to understand something when his salary depends on his not understanding it. And I think that would be a good example of the fee-for-service system influence on reducing low-value care. So, to change behavior, most people believe that accurate, meaningful data should be sufficient, and most medical directors of insurance companies and health physician organizations would like to be able to purchase a software package, deliver information to practitioners, and have them change their behavior, and that just doesn't work. The second piece is having clear, accessible reporting tools. I think many medical directors like to bring reams of paper to practitioners. I did a project for the American Medical Association looking at what national health plans provide, and really what we found was that the plans couldn't figure out exactly what they wanted their physicians to do, so they dumped the data on the doctors, and the doctors couldn't figure out what to do, and so they just threw the materials in the wastebasket. So having these clear, accessible reporting tools, which I'll talk about, is critical. And the other pieces are having core values. As a medical director of an IPA, honesty was one of our core values. I said whenever I visited a practitioner what our core values were, and they were pleased to know that honesty and respect were two of our primary core values. There has to be inclusion of leadership in the support for the program. We'll talk about that. There has to be a reason for asking practitioners to change. And then there has to be an interpersonal process that is successful, and I'll talk about that some too. This issue of using money as a primary tool to change behavior is something that I think many find very interesting, and people generally believe that it's what physicians want. My experience is that that's not exactly correct. And Ed Deasy and Rich Ryan developed a theory of self-determination that proposes that internal motivation is more important than external motivation. There's a video that you can view, which I have on the bottom of the slide, The Surprising Truth About What Motivates Us, and that you can look at. It's quite excellent. And there are three areas that are responsible for internal motivation. One is competence, which means that the thing you're asking people to do is possible or achievable. The second is autonomy. Physicians hate being told what to do, so they can agree on what needs to change. And then in general, the medical leaders have to give up some power to share with practitioners to develop a strategy to achieve that. And that is counterintuitive to how many medical leaders think things should go. And the third thing is relatedness, which is practitioners want to do something that's meaningful to the community as a whole. And that's the reason for talking about patient safety as one of the major components of reducing low-value services. And the final thing is to do those three things in the context of core values, which I mentioned already. once people believe that they're doing the right thing or the appropriate thing, and they internalize that, they continue to do it regardless of whether they're paid to do it or not. And so as a strategy, internal motivation based on choosing measures to focus on that are appropriate makes a lot of sense. And I think practitioners are interested. When I have cleared the way of misaligned incentives, practitioners choose appropriateness repeatedly. This is an example of the variation that exists in everything that we look at. This is a chart of gastroenterology practices in Massachusetts. You can see that this is the frequency with which an endoscopy is performed on a patient with reflux esophagitis. The group in the middle where the arrow is one of the groups, is variation in the frequency with which endoscopy is performed between 15 and 85%. And what we did with practitioner groups was that how could it be possible that 10% or 15% and 85% are both the correct amount of scoping that patient is required. But more importantly, if you're looking at behavior, the closer you get to the individual, the better. So this arrow is pointing on one group. Most people believe that the group's participants practice similarly, but this is the scoping pattern of the people that were within that group. And you can see that there's variation between 28% and 68%. And so within groups, there's as much variation as between groups. I think it's important as we design interventions that we try and focus as closely as possible on the individual practitioner. So if you look at this, the percentage of scoping was about 46% in Massachusetts. In central Pennsylvania, it's about 72%. And so the benchmarking of these comparisons becomes important. These were individual gastroenterologists, not practices. And as we looked at it further, we found an interesting finding. About 90% of the times when individuals were endoscoped, they were biopsied. And we took out people with Barrett's esophagus because those people should be biopsied. So these were people with uncomplicated reflux esophagitis. People were getting biopsied at a rate of 90%. At a meeting, I participated in, we asked people why they thought the biopsy rates were so high, and they said it was because they owned the laboratories. And so the incentives were misaligned. I'm going to go fairly quickly now through the rest of these slides. The relationship between quality and cost is something that's only recently started to be studied. A lot of physicians will say, I cost more, but my outcomes are better. This is a thing that we published that showed in hypertensive care that there was no correlation between cost and quality of any hypertensive treatment. I'm going to skip this one. So these are the components of a successful program. First, senior management and board have to buy into the use of the program. If the senior management doesn't agree, when someone comes complaining to them, they'll take it out on the people that are trying to change behavior. You have to form an interdisciplinary team anchored in the project's core values. I think these core values, when I have done leadership meetings with medical groups, about half the groups don't have core values that they can share with their members. It's better if there are clinical champions for each project. I did a neurosurgical project in Massachusetts, and one of the neurosurgeons stepped forward and offered his assistance in talking with chiefs of neurosurgery within the Boston hospitals. That's much more effective than having an internist do that. We talked about creating accurate reports that are dramatic and deliver clear, respectful messages. I can't stress that enough. And probably most important is to develop conversations with physicians that are non-judgmental. If you let a person who's spending a lot of time doing their work know that you think that they're overdoing things in some irresponsible way, they defend themselves. And physicians are very good both at getting even and protecting themselves. Then after you create the beginning of the program, you have to collaboratively construct a way to address the problem. So that's developing a quality improvement plan. That's sharing autonomously with the practitioners what they think would work. You have to offer ongoing feedback that, again, is non-judgmental, and in summary, I made it respectful. You have to communicate regularly with the project team, with key sponsors, to let everybody know what's going on. And you have to use tracking tools and report the interim measures through the board, through the executive committee of the organization, through the medical directors, and then through the participants. And finally, you have to praise success. If people are doing a good job, you have to reward them one way or another. I, as a practitioner and medical director of an IPA, used to create these small certificates of praise, and I was surprised at how frequently, when I went to doctors' offices, they had framed them and put them on their walls. So people appreciated being recognized as being an effective practitioner. I do want to make a couple of caveats. One is that if you expect to go from denial to acceptance, you're going to have a really rocky road. Elizabeth Kubler-Ross articulated the stages of change, but these are truthfully the stages of death. These are truthfully the stages of change, and that people go through anger and bargaining before they go to acceptance. We taught our office staff to identify the stage of change when people called, because we had scripts written for anger, for bargaining, and for acceptance. So we treated people differently based on their stage. The last thing is how much data is enough. And what I found was the less data we presented, the better, because we tried to make it as clear as possible. These peer comparisons are incredibly compelling to people when you show variation. If they find that there are people who they respect that do things differently than they do, they did not know that. They had never seen comparisons of their work with others before. And so the simpler and more clear one can show these variations in service provision, the more compelling it is to people. And in general, I don't talk initially about what's the right thing to do. I ask them what they do and why they do it. And once people start these conversations about what's correct, as non-judgmentally as possible, their defensiveness decreases, and they actually start thinking about what they could be doing in a different way. So that's my sense of what can be done. These are references that we've published that show either how to do the work or the results of the work. I look forward to your questions and comments, and hope you found this worthwhile. I'm going to push the stop share button, and Brian will take over now.
Okay, great. I don't know if we can get rid of our pictures on the right-hand side. I'll be showing some data over there. If not, no worries, but I will be showing some data on that part of the slide in a bit. I want to first thank Tim and for inviting me. I'm really honored. I'm a big fan of Choosing Wisely, and I'm a big fan of Howard Beckman. And so just to share a webinar with Howard on this topic that I think is just so insightful and important is really exciting to me. I think you'll see that we've implemented many of the things that Howard just suggested, and we'll show you some kind of a real-world application of some of the things that we've done here. Good. Thank you. Okay, so it comes down to so much comes down to communication and creating that infrastructure of trust. When you have open, honest, and respectful communication, and how does that create the relational component? And Howard's done a lot of research in this area, and certainly my real-world applications or education on this was in the doctor-patient relationship as well. And so I think we've both been working to translate that into our areas of healthcare. We've chosen Spine, my health plan, because it's a good thing to attack. I don't think there's any other area of healthcare that is more inefficient in this very inefficient system. Over the last couple of decades, there's been the cost of care and back pain and spine pain in general is even outdistanced the rest of healthcare. Meanwhile, disability is going up. And I'm not sure you're going to find that combination at this level in any other area of healthcare. Why is that? That picture of the United States to the right is from the Dartmouth Atlas, but there's high variation at every level of care. And so you just can't blame any group. I have spine surgeons that use it 17% of the time and some who use it 93% of the time. But same thing with pain interventionists. Physical therapists are sometimes active or passive. Chiropractors are all over the board. Primary care docs are very anecdotal. And so with that level of high variation, there's always going to be lack of quality. The supermarket is, in tribute to Scott Haldeman wrote an article and identifying, and he called it the supermarket approach to back pain, where he found over 200 different treatment approaches to back pain, 24 different practitioners. And on top of that, all that high variation. No wonder there's confusion, and no wonder there are trends continue to rise. And so my health plan recruited me out of practice after I had already helped what is now a Beth Israel Deaconess Hospital develop a spine care pathway. About 8 years ago or so, we published that data, and that model is starting to gain some traction around the country. But it's not that complicated, really. It's just a good cross-discipline evidence-based pathway that's evergreen. It's engaged locally with the providers. They're part of it. They build on it. They own it. Do some training so that everybody can get on the same page as far as language and approach and communication styles, and then you're going to bring value to the community. And what that does when you have that infrastructure of a care pathway, it opens up channels for sharing issues about satisfaction and safety and quality and cost data, and also the clinical data. An example of that is just a few weeks ago, there was a really, I think you might find this being one of the most impactful spine series ever written. It came out in Lancet about 3 weeks ago. And 3 days after it came out, I was giving a weekend presentation with surgeons and primary care docs and chiropractors and physical therapists all in the room together. And I was able to share that information when it was 3 days old, as compared to, you've seen some of the literature where sometimes it takes 17 years for best evidence to make it to the bedside. So we created that infrastructure. We really focused on the early contact providers, because the first impressions make a big difference. The things that you say, the motivation that you instill, the expectations you create, the tests that you order have huge impact in downstream quality and cost. And so we go through this care pathway through a training of usually 1 to 2 hours of primary care. And then a subset, we've written a couple other published articles on societal need for what we're calling a primary spine practitioner, which is really degree agnostic, but any of these practitioners that you see on the screen that want to step up, we do a 24-hour training. University of Pittsburgh is now doing 100 hours, and it kind of built on our concept. We're very happy about that. But the basics of both those trainings are the things we've talked about. Engaging the patient, changing that culture from passive pharmaceutically based care to active, engaged care about quality of life and about the whole person in a biopsychosocial model. And really that redefining spine pain, getting away from pain as a fifth vital sign, which is a mistake for certainly for spine pain. Even calling it back pain, I can make the argument that it creates a hypervigilance on both the patient and the provider's part to focus on a pain. And that is not where you want to focus back pain. You want to focus it on quality of life, on function, on productivity, the things that are meaningful. And that's where you're going to get an active engagement from the patient. Let's jump into choosing wisely. Interestingly, the most recommended suggestion in all of choosing wisely is don't image low back pain in the first 6 weeks of uncomplicated back pain with no red flags. And there are actually 6 different societies that came up with the same recommendation. So how did we implement that? Well, first we built a data set that would build that, and then in discussions with Milliman, their MedInsight team kind of put their power behind it and made it bigger, faster, stronger, better. So we're now using their waste calculator tool. But here's an example of that. And what they did is they found with one of our ACOs that there were 1,600 services MRIs done. Of those, through their data, 1,100 of them were wasteful. 1,100 of them did not meet the best evidence criteria. And you can see a pretty good piece of change there, $400,000 in savings. But the important thing here isn't just the $400,000, but what are the downstream ramifications of ordering an image? And that's where the true savings lies. And let me show you some studies that verify or support that. And this is the studies that are so important to show the provider so that they can, the providers, as Howard said, they want to do the right thing. They really want to engage in patient safety. And when you can show them how just ordering an MRI can create bad downstream ramifications, they change your behavior. So here's actually two studies I put together because they were both randomization. One was plain film, one was MRI. You come in with back pain, you either do or don't get the film. Both of them showed lower self-perceived health status, more likelihood of persistent pain, and more office visits. This study is a workers' compensation study, and intriguingly called iatrogenic consequences of MRI. And from this study, inappropriate early imaging, the probability of increased cost was, they estimated at $13,000 on average, strong iatrogenic effect, no downstream benefits, and worse outcomes. The only difference was the inappropriate order of imaging. So it's not just the cost of the image. This is a study that was in the American Journal of Neuroradiology a couple of years ago. This chart we are pushing throughout our communities. In fact, we're actually embedding it into the MRI reports of upstate New York. And you can see if a 60-year-old comes in with acute back pain, gets his first MRI, and he sees this diagnosis of degenerative disc disease, which is two fear-invoking terms. He and people used to come to me all the time and say, "Oh my gosh, doc, I've got this degenerating back." And that puts them on a focus of someone needs to fix them. It looks like an illness that needs to be cured as compared to a part of life that needs to be managed, which is really what back pain is. And so when you have this epidemiological data in front of them, you say, well, look, 88% of healthy people have this. It really calms the fear and gets them focused on what they need to do, because we're using language in spine that we don't use other places. We wouldn't say this really healthy, dynamic lady that her wrinkles are degenerative skin disease or her gray hair is degenerative hair disease, yet we are inducing those kind of fear, invoking those kind of fears with our back languaging. So we're really focusing on the languaging of our providers between each other and between their patients. Why? Because language makes a difference. I thought this study really brought that out. They showed people those kind of findings on MRI, and even though they were asymptomatic, they said, if you had those findings on your back, would you have surgery? And half of them said yes, even though they were asymptomatic. So the power of language here. So once the providers engage and understand the reason behind the Choosing Wisely initiative, it makes a big difference. And then we give them the tools to make that happen. So the tools to share with their patient. In fact, we give them your tools. Thank you, ABIM, for creating these, and we've created a relationship with you to do that, which has been wonderful. As Howard suggested, we also create a provider profile so that we can show them some kind of how they benchmark in a few key areas: imaging, specialty visits, and opioid use. And we know that those three are the big three drivers of complexity if they're inappropriately utilized. I'll give you a quick story. So one of our ACOs said, well, Brian, why don't you come in and just train half of our primary care doctors, and we'll wait a year and see what it does. It was a natural experiment. I said, sure. We had trained a cohort of primary spine practitioners, mostly about 50-50 chiropractors and physical therapists in that community ahead of time. And then we went to a 90-minute training with primary care, and we had a physician champion there who just reinforced the lessons of the 90 minutes throughout the year. He said, not with much time, just bring it up at meetings. A year later, the group that we trained had a 28% reduction in their costs, and the other half of the same ACO that we did not went up 8%. That was a pretty dynamic change. And to stick with our imaging theme, I just looked up this data, but their imaging dropped 27% after the training of their ordering of just MRIs alone. And this is in spite of the fact that we had a pre-authorization vendor who's been working with them for 10 years. So even though we had a vendor, we still were able to drop it another 27%. And this last slide, this somewhat busy slide, is just how we go into a new ACO and how I introduce the program. And so while I can't show you true PMPMs, I've made all of the new to us ACOs at $1, and then the group that have been working with us the most, which is about 4 years now, is that trained ACO. And actually, it works out better because you can easily see the difference in costs. And you can see 41 cents for every 41 cents is being spent with the ACO that we've worked with the longest for every dollar being spent at the one that's new to our group. So we like to show this kind of data set to people, and we like to show, we were transparent. We understand there's a difference in risk scores, and in the top right corner, you may not be able to see, but there's a different percentage of members who actually present with back pain every year. And the new ACO had almost 1 in 4 people every year presenting with a back pain diagnosis, or a spine diagnosis, which is really high. And we're finding that our groups, that number drops as well, because part of the training is teaching the patient to engage in self-care, in self-management skills and self-triage skills. I'm not sure if you can see the part I circled, but that again, that's specifically the imaging total. And the new ACO is about, utilization per 1,000 is about 150. And with our trained ACO, it's less than half of that. So this is Howard's 10 steps. I hope that you picked up on that. I've kind of learned and implemented many of these, and we're using some of these to train our ACOs to translate the data, because we're finding that that's where a lot of things break down. It's not the data itself, it's the translation of the data that makes the difference. So thank you very much. I think we're ready to hear your thoughts and questions, and I'll pass the screen back over.
Thank you, Howard, and thank you, Brian, for a great presentation. And we're now going to hear from 2 responders. And our first is Risha Gidwani Marzowski. She is a health economist with the VA Health Economics Resource Center in Menlo Park, California. She's also a core investigator with the VA Center for Innovation to Implementation and a consulting assistant professor of medicine at Stanford. And she's been principal investigator on studies evaluating the overuse of MRI for low back pain and overuse of intensive medical care at the end of life. Risha?
And Brian, for your presentations. I found that they were both really interesting to hear. I'm particularly interested in starting with lumbar spine MRI, and my reason is because I did some work in the VA where there are no financial incentives for overuse of lumbar spine MRI, and looking at the entirety of lumbar spine MRIs that were performed in 1 year, we found that 31% of them were inappropriate. I think, Brian, that's much lower than the data that you presented in your population, which is about 68%, if I read those slides correctly. But interestingly, we found that only 10% of physicians were responsible for 50% of inappropriate slides. And so if there is a small group of physicians that's really driving the overuse, I'm curious to hear actually from both of you as to whether you think pathways or programs that apply to all physicians are going to be the ones that are going to be most useful, or how that might relate to sort of decision fatigue or pathway fatigue for the physicians that are not necessarily responsible for the problem.
I'll start if you don't mind, Howard. I think when it comes to imaging and the impact on downstream quality and cost, I think it's important for all practitioners to hear that. Even if they're ordering at appropriate level, that it opens up the dialogue about the importance of languaging. And at the VA, I would really encourage you to think about doing, and we can share with you some of the templates that we're using in upstate New York here, of embedding some of that data into the MRI. There's been some studies, one by McCullough, that showed that just embedding that kind of language into the MRI has a big impact on downstream utilization. But I totally also agree with you that in fact, we're doing some initiatives internally looking at, can we get away from utilization management and start doing outlier management? And I think feeding off what Howard said, it's more respectful to the practitioner. Can we find ways to really focus in on the outliers when it comes to utilization or cost data?
Mm-hmm.
So I'm gonna, can you hear me?
Yep.
I'm gonna, one of the things I talk about in this non-judgmental approach is eliminating the word outlier. So in general, I think showing the variation that exists allows each practitioner to reflect on their behavior. And I think that's a more productive way than, as a practicing geriatrician, I found that when people dumped more and more guidelines on me, I just but I threw them away mostly. And that's because it diminishes my autonomy as a practitioner. So I want to think about what I'm doing. What I don't usually have is information about what exactly I'm doing compared to others. And so I think that this kind of information needs to be very selective, very targeted. That's interesting. The sharing of it with people that do less and do more is interesting because people talk to each other. And what it starts to create is an openness about sharing information about what each other do. And it creates really meaningful conversations amongst practitioners.
Great, thank you. Howard, I'm particularly interested when you're thinking about opportunities that will help support change in the practice, what your thoughts are about some behavioral economics principles. So for example, choice architecture is one principle from behavioral economics that encourages the preferred behavior as being the default behavior. So in the case perhaps of lumbar spine MRI, the provider would have to opt into the MRI, or there would be some sort of more friction to ordering an MRI than there would be to not ordering the MRI. I'm curious to hear your thoughts on the role of choice architecture in helping to create physician behavior change.
I think it would be really exciting. I visited the New York City Department of Health, and one of the things they've done is they've hired a behavioral consulting firm to go over all their programs and literature to try and make sure that they get the optimal use of behavioral economic theory in their work. It's not something I've had enough exposure to, but I think it would be great.
My 2 cents on that would be we have to be sensitive to how much work is this at the provider level? Primary care burnout rate is an all-time high. So if we do something, if that friction you mentioned is perceived as yet one more hoop to jump through, I think you're going to get pushback, and implementation is going to be impacted.
When you are thinking about services that are good candidates for reductions in overuse, what are the characteristics that you're looking for? Is it that there is a large number of services being overused, that the services that are being overused are high cost, have large downstream consequences, are being overused by a large number of providers? Are there any sort of rules of thumb that you can provide to practices that are interested in de-implementation as to which services they should prioritize for those processes?
Yeah, so looking at high cost, high volume procedures would be first. And then making a list of the potential procedures that you could focus on is what we recommend. Then you go through the list and say, what specialties are most likely to be successful in working on this? So I used to say that the last group I would choose are orthopedics, because they were the group that I had the most trouble with until I worked with Blue Cross of Massachusetts, and they had some orthopedic groups that were unbelievably creative in how they wanted to approach the use of procedures. So I think it's a combination of likelihood of dramatic change and the willingness of the specialty to consider or reflecting on their behavior to see if they could do it differently.
And if I add on that, what we do too is we give them a list of what we found in our data look, and then let them have some choice in the matter. It's kind of self-determination theory at the ACO level, so that they can be engaged and have more control. We certainly don't dictate.
Thank you. And just one last question that I have is how de-implementation interfaces with patient satisfaction. So there's some literature that shows that patients prefer to have services, they prefer to have imaging, they prefer to have labs, they prefer to have prescriptions, even if those are unnecessary. As the world has already shifted to including patient satisfaction like CAP scores, in assessments of physician performance. How do you see sort of the conflict that may occur between a physician performing appropriately by de-implementing services and that potentially causing a reduction in patient satisfaction that could come back to that physician in a negative way in the future?
So I think most patients have bought the model that more is better, and that needs to be addressed. I think the best I can say is that in shared decision-making tools from the Mayo Clinic, I've seen their prediction of the benefits of doing something or not doing something. For example, taking a statin for coronary disease, the results, because I have trouble taking statins for my coronary disease, I was very interested in how many lives would be saved or how many heart attacks would be prevented by doing a particular thing. If you did that same kind of analysis for low-value procedures, it would be remarkable evidence that doing something could cause a lot more harm than good. And it's the honest transfer of that information that's required if you want to use patient satisfaction as an outcome for this. Otherwise, you're going to subject people to things that are going to harm them for bad reasons.
In spine pain, it's really interesting because if a patient comes into a primary care doc and says, I want an MRI, I want an opioid, and I want to see a surgeon, which happens fairly frequently, and they have no, progressive neurological deficit or any indications for those things, no red flags, the good provider is going to say no, no, no. Their patient satisfaction score is going to drop, and they were being the appropriate provider. And so, what we're trying to do to help our primary care docs with that is to make these decisions come from community, not from the individual practitioner. And so, we're creating some shared decision tools on why the community standard for the necessity for an MRI is this, and what are potential harms of opioid use, and just to try to offload our primary care docs again from kind of being the bad guy. We do have some patient satisfaction outcome from some of our ACOs. So Press-Ganey scores have actually gone up with our spine pathway implementation. But again, I think the key here is to support the primary care docs to make the right decision, not the popular decision.
We also just, as an addition, created patient pathways. So if someone had upper respiratory infection, we were trying to encourage people not to use antibiotics. We developed an IPA-based patient pathway, so that it wasn't the physician that was withholding antibiotics. They were doing what the community asked them to do because it was better for patient care.
Great. Well, thank you. This has been a pleasure to chat with you all. I think those are the extent of the talking points that I was hoping that you could provide feedback on. So I'll turn it back over to you, Tim.
Thank you so much, Risha. And our second responder is Jordan Harmon, who's the Director of Advocacy at Cost of Care and the Managing Director of the HHS Center for the Advancement of Value in Musculoskeletal Health at the Hospital for Special Surgery, where he focuses on helping clinical teams deliver high-value care. Jordan?
Thanks, Tim. And Risha had such good questions that she actually hit on a number of mine. So I'll ask two, and then maybe we can get to some of the others on the call as well. So Howard and Brian, thanks. Amazing presentations, weave together perfectly. So first is for Howard. So Howard, you talk a lot about, financial incentive isn't the only thing that's going to drive a clinician, specifically physicians. I do believe that you talk about, competence, autonomy, relatedness. You also mentioned earlier that one of the big, questions is sort of how to structure the right contract. So if I'm sitting on the other side of the table, any advice that you could sort of share, any KPIs that you could sort of share for somebody who's looking to develop these kind of choosing wisely initiatives into a value-based contract? So that's number one. And then for Brian, one of the things that you touched on was shared decision making, and that was going to be my question. But I guess the bigger question is, how do you sort of incorporate the shared decision making tool into sort of an EHR? Are you doing that? Because one of the things that we've found at HSS is some patients, like you mentioned, come with a preconceived notion of what they want or what they need, and so it's sort of trying to figure out how to support the decision that's the right decision in providing high value care for that patient. So interested to hear both of your feedbacks.
Brian, you want to go first?
Sure. As a payer, we don't have control over the EMR systems, and they vary between upstate New York. But what we're trying to do is to make these shared decision tools available, whether they're simple ones like, do you need an MRI? But also what we're working hard on is we're just finishing up what we're calling a patient roadmap or a patient decision guide. And the idea being that we're really taking a patient with back pain through 5 steps. You have your acute episode of back pain. So first step is don't panic, because if you get too anxious about your pain, you're probably going to make some fear-invoking decisions, or maybe run to the emergency room when you don't need to. 2 is, do I need care, which is taking them through a self-assessment, self-triage process, and if they don't need care, things they can do. If they need care, who should I go see? Do I need to go to the emergency room? Do I need to go to primary care? Am I better off, seeing what type of practitioner? And then the next set of questions is, what questions should I ask when I get to that practitioner, so that they make sure that they are engaged in their own recovery, and that the practitioner is also going to be an active care practitioner, not a passive one. And then finally, what can I do to heighten and speed up my recovery and possibly prevent the recurrence of this condition? And so that whole patient decision guide, we're just finishing up, but our goal is to, again, push that through the entire community. Our Chamber of Commerce and our employer groups are already ready to go. Our ACOs are ready to start distributing it. And we're trying to find ways to actually push it to patients. If they call to schedule on Tuesday and for back pain and are supposed to see a practitioner by Thursday, it would be great if we can push it to them that day, so they can pre-read and be pre-framed on that. I don't need an MRI, I don't need an opioid, I probably don't need a specialist intervention, and these are the things I can do. Or maybe I don't need care at all, and I should just be patient and see how it feels for a day or two. So again, we're always looking for a community base, that this document is coming out of community and that's being distributed through community, so that we can get a common language through our communities, because that's the only way you're going to change a culture.
So the first part of the question was about value-based contracting, and I'll give some thoughts. There in the reference sheet, there is a paper by Dana Safran from Blue Cross of Massachusetts and myself and Patricia Healy about how medical groups and health plans can work together more effectively. And so I definitely suggest that you look at that. The things that I found helpful as Dana and I talked were, I think the value-based contract, the alternative quality contract that she developed in Massachusetts, is a good example of how things might work. And what happened was the health plan and the docs were encouraged to be honest with each other. So rather than trying to get the benefit of a good deal or something else, the health plan said, what we want is to keep our costs at consumer price index increase, because that's what our employers want. And if you can save money by doing more efficient care, you can keep most of the dollars. And then they added in a stepped approach to maintaining quality that added quality to the paradigm. And the groups were clear. I think I talked earlier about the medical groups are not trusting what the savings go to. In this case, everything was transparent. people agreed on what they would get and what they wouldn't get up front. And the health plan was, I think, quite honest about what it is they wanted. The second thing is creating these changes in practices takes time, and it takes upfront dollars. So I think the health plans are still reluctant to upfront the cost of changing behaviors, and want returns quicker than they're available. So at least in Rochester, what I've seen in our blood pressure collaborative is that we're starting to see some changes in how the practices are doing their work after about 7 years. And initially it was 6 months, and then it was a year, and then it was 2 years. People seem disappointed that practices don't change. It's very difficult to change the culture of medical care, especially in the face of the fee-for-service system still dominating. So I think it makes it much more complex. I'll leave it at that.
And those are both really good points, and exceptionally challenging, especially with employers where employees are switching on and off plans. Hard to get a good sense longitudinally. And then Brian, thanks for your comments as well. I think very important points, and ones that we could probably talk a few more hours on. But I'll flip it back over just in the sake of time, so that others can ask questions as well.
Thank you, Jordan. And we do have a few minutes left, and would love to hear any questions from the group. You can go ahead and unmute yourself if you're not unmuted already, and just please feel free to just speak up and ask a question of our presenters. You can unmute yourself in the bottom left-hand part of your screen. Well, I'll go ahead and ask a question then. Howard, at the beginning of your presentation, you advised making the case for reducing overuse as a patient safety issue. And just curious about any further advice that you would have for providers about the best ways to do that. Yeah, and you too as well, Brian.
So I think I wrote a piece in the Annals of Internal Medicine in 2011 about learning to become bilingual in medical talk. So when you talk to physicians, talking about dollars saved is not very satisfying. And what I found as an IPA medical director was that if I talked about doing the right thing, people got quite engaged. And I've seen a number of projects where physicians chose behavior change that was not in their best financial interest. So among cardiologists in particular, it was very impressive to watch. And so this idea of picking measures that are evidence-based and encourage people to do the right thing is very satisfying. We did a project in California with back pain and Medi-Cal patients in a health plan called Partnership Health Plan. And all we did was go to primary care doctors' offices and share information about the lack of benefit for spinal injections, which I think the literature has shown a couple of times now to be less than helpful. And within 6 months, the change in behavior was unbelievably dramatic. The primary care docs just stopped referring people enough so that we were concerned that someone had maybe murdered the person that did the injection. So we sent someone to California to make sure they were okay. And it was an unbelievable response to non-judgmental sharing of information and giving people a variation chart to show where they were on those things. I think this is not incredibly complex. I think it's aligning the incentives so that people aren't encouraged to do something that is against their best interest. And we found in a number of studies that that if you ask people to do the wrong thing and pay them to do it, they might do it, but they'll hate you. And as soon as you stop paying them to do it, they'll stop doing it. And so again, this issue of internal motivation is much more powerful than external motivation.
And I'll add a little bit to that, and that is, I continue to be concerned with that the downstream effects of a false positive. So just ordering a test is not a benign decision, because the ramifications of a false positive and the tests and interventions that can happen from a test that maybe shouldn't have been ordered in the first place has safety issues, and I'm not sure that we focus on that enough. Certainly, in the spine world, that's an area that is a huge impact. We're actually creating chronic back pain patients because of bad decision making on the front end.
Thank you. We are at the end of our hour. So I just wanted to conclude by thanking Howard and Brian and Risha and Jordan for their great contributions today, and thanking everyone for joining us. And we will have another one of this type of webinar in July, and look forward to speaking with you all again then. So thank you very much.